we were discussing yesterday septic shock, and there was one thing I just need to ask you if because I think I did not stress it very well. I will ask again to any one of you, anyone who wants to answer this question: mixed venous oxygen saturation. Okay, why we take from pulmonary artery? Why we don't take it anywhere else? Can anyone answer? Because I answered half of it, and I actually forgot to mention yesterday. So I just want to clarify that thing. Anyone, please? Mahjabin? Or anyone who wants to speak out? Sumaira, Tayyab?
Maybe because no shunting at this area, so
No.
it is.
No, Dr. Amir. It's not the reason.
Mm.
Yes, Sumaira.
Sir, maybe in pulmonary artery the blood is properly mixed at the site, so we
Is
that's
there
why we take
is
separate
there
from the.
is there hand mixer over there which is mixing the blood properly in pulmonary artery only?
It
Sir,
might be due to that.
Yes, Mahjabin.
It might be due to that the mm, the blood is oxygenated in lungs, and then after the admixture of that part of blood that is shunted and not.
No, 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 no,
Uh,
no, no. I'm sorry. I'm sorry. You are wrong. You are wrong. Actually, yesterday I explained some one of the part of it, that if we are checking the venous oxygen saturation in the sample from the central vein, which is easy to get. Like for example, you have a central vein and you just check the central venous. There will be what will be the difference, that because oxygen extraction in the upper half of the body is more. Okay, brain is extracting more, so that will be a little uh, unreliable. Okay, and when so it is entering the right atrium from the superior vena cava, and the venous drainage which is coming from the lower limb. Here it also deoxygenated blood, but oxygen concentration is relatively higher as compared to superior vena cava. So that blood is mixed now. Okay. Now it is entering the right ventricle. So theoretically, if you have something in the right ventricle, that should also be telling it. But there is one more thing which is being added in the right ventricle. What is that one? Which is changing the composition a little bit. What is that thing?
Sir, there is coronary drainage as well.
Very good. The venous drainage of heart through the Sebacean veins open in the right ventricle or left ventricle. Okay, it comes in the ventricles. Okay, that is the thing which is making it now. That is also with low oxygen, because heart also extract more oxygen than any other body organ. Okay, so that's why then when this all is mixed, we are taking the sample from the pulmonary artery. Okay, that is the thing which I just wanted to clarify more, because it was missed yesterday. Okay, so today we have, like, we started from the basic concept of shock, and then we discussed about some variety of presentation of shock. Okay, and then we entered into the concept of septic shock, and we just touched some of the parts of sepsis as well. There was the next type of shock which is important is cardiogenic shock and obstructive shock. Okay, so actually some of the components are together, so we will just try to cover as much as possible. So how cardiogenic shock occurs? For example, if you what do you mean by cardiogenic shock?
It is due to pump failure that heart isn't pumping the blood adequately.
Okay, So we are talking about pumping of the right side of the heart or the left side of the heart.
Left side
Because
of the heart.
because there are two pumps. Am I right?
Yes.
Okay. So if we just concentrate on the left side of heart, for example, so what will be the sequelae? Like why, for example, what do you think? Why this pump will be failed? You are right. That pump is failed, but why?
Due to dilated cardiomyopathy.
Okay. Cardiomyopathy, one of them, one of the factor. What else?
Any rupture of the heart wall.
Mm, you see, like it is a
Decreased in
pumping.
contractility
Yes, decreased
of the heart.
contractility. Decreased contractility of a heart, maybe because now the muscles are dying, or muscles have acute ischemia leading to infarction. Usually, that will be the main factor. Okay, or there will be because of like this cardiomyopathy, or this may be because of any reason. Okay, it may be because, for example, if there is myocarditis, there are some viral infection which can lead to failure. Okay, there may be some cardiac depressant medications which can cause a problem. Okay, we have a patient with the hypertension. Now heart is chronically under pressure. It initially became hypertrophied and then fail. Okay, there may be some other pathology like that. Okay, there is, for example, aortic regurgitation. There is a chronic and like heart is dilated, and then goes in failure. Okay, so that is what's happening, and the end result is decreased perfusion. Okay, the decreased perfusion will be in the form of decreased cardiac output or decreased blood pressure. Okay, so if there is hypotension, this pathway will may be initiated. Okay, there is sympathetic response, baroreceptors will respond, and chronically all the systems will be involved. Cardiogenic shock may be acute or may be chronic. Okay, acute will be usually in the infarction, for example. The end result is either arrhythmias or failure. Am I right? Whenever there is myocardial infarction, what is the result? The end result occurs like this. Okay, end result is in the form of failure of the heart to pump, and the result is the lack of perfusion of the vital organs. Am I right?
And organs.
Initially, body will be responding, so that stage will be compensatory shock, and later on the body itself, this compensation will lead to a vicious cycle leading to a decompensated state. Okay, so this is the basic concept of whatever, because whenever there is a sympathetic stimulation, there is increased heart rate, increase. Actually, you see, this itself is creating a problem. Okay, heart is already failing, heart is already under stress. The cause is maybe ischemia, and the heart rate is increasing now. When heart rate increase, what happens? Not only the requirement is increased, what is the other effect? How it decrease the supply, the heart rate? Anyone
There
wants
is
to?
less time for chamber filling in tachycardia.
Diastolic time will be decreased.
Okay,
Diastolic
Mahajabi?
time will be decreased,
Yes,
and
diastolic time will be decreased, so it will
decreased.
have.
So the cardiac perfusion will be decreased. It
Your
further
actually, I'm
worsen the
sorry.
ischemia.
I apologize. Actually, your voice is quite distorted. So if you can fix it, it will be
Okay.
better for everyone, because we are recording. In the meantime, Mahjabeen,
Yeah.
can you rephrase again, please, what he was saying, Surya?
Uh,
I'm sorry, just unmute yourself, please, Mahjabeen.
in tachycardia, the heart chamber filling time is reduced, and then the reduced cardiac output is there's a reduced cardiac output, and in turn causing hypotension and inadequate oxygen supply to the organs.
You can
and
improve your
myocardial.
answer. You can improve your answer a little bit. When there is increased heart rate,
Yes.
both systolic and diastolic times are decreased, but there is more effect on diastolic time.
Diastolic phase.
So when diastolic time is decreased, is it only the filling of the heart which is problematic, or is there anything else which you should be knowing? There is something else which is important. When there is reduced diastolic time, there is another important thing which occurs. What is that?
The coronary artery supply is during that diastolic.
During diastole. Okay. So
Yes.
actually you are just creating so much problems for the heart by increasing the heart rate. Okay. So this is a message. If you want to check yourself, okay, keep look on heart rate during anesthesia. If your heart is swinging like anything, it means your anesthesia is inadequate. Okay. So whenever you are managing a patient, if you want to see that you have kept a good depth of anesthesia, try to manage it between 10 to 20%. Okay. If you are not able to keep the heart rate in that range, it means you are not giving a good anesthesia. Okay. And practice this thing in a normal patient, because maybe normal patient, nothing will happen. Okay. But if you suddenly have a patient with mitral stenosis, or a patient with heart failure, or a patient with ischemic heart disease, if you are not able to control the stress, then it will be detrimental in that patient. Okay. So whenever there is increased heart rate, increased oxygen demand, there are more chances of ischemia. The demand is increased and supply is decreased. Okay. So whenever there is ischemia leading to pump failure, increased left ventricular and diastolic pressure, because heart is not able to pump nicely, and then increase, and it is going in the back direction. Okay. So if you are concentrating on this slide, for example, actually the same thing happens in aortic stenosis. Okay. When there is aortic stenosis, the same thing is actually occurring. Or in, for example, chronic hypertensive patient, where there is increased afterload, actually the reason of failure at the end of the day is like this, that chronically what is happening, chronically the heart is under stress, there is hypertrophy, there is decreased chambers, and then contractility is initially compensated, but later on it is going down and down and down. Okay. And then next effect is on the atria, and then from the atria, because it is connected to the lungs, and then gradually, because the lung vasculature is very delicate, if you are chronically exposing it to high pressures, it is getting angry, and when they are getting angry, chronically they will become pulmonary hypertension. Okay. And the same patient, if you are if there is any acute insult on this chronic problem, patient will go in what condition? What will be happening at that time? For example, if you heart is under stress and you give more fluid, what will happen?
Pulmonary edema.
Pulmonary edema. The acute decompensation will be actually I am really sorry, Surya. You are not able to listen to you. I apologize for that thing. So what happens, that acutely it occurs, the vasculature pressure goes back, and suddenly the fragile vessels leak out, and there is pulmonary edema. Okay. So actually, if you understand this thing, this is the same pathophysiology which occurs even in mitral stenosis. The same thing occurs even in aortic regurgitation or mitral regurgitation. Same. The basic mechanism is the same. There is a overload of the door is closed, or door is having more resistance, so the back pressure is coming. So if there is chronic back pressure, first of all, there is dilatation of the chambers, there is a stasis of the blood. It is that pressure is being conveyed back to the mesquine, to the simple lungs, and they are not ready to cope this. So next step is pulmonary hypertension. And then what happens? That stress is generated back to the right side of the heart, right ventricle. Okay. So the right ventricles who are actually are not made for this high pressures, so they fail. Okay. So the symptoms and signs, if you correlate, initially when the left heart is failing, the symptoms are predominantly in the form of cough, sputum, pulmonary, like it will be pulmonary symptoms in that way. And then if it is going back, now it is becoming the edema, the peripheral edema. The JVP is raising. There is a hepatic congestion. There is a hepatojugular reflex. Okay. There is a pitting edema, which is occurring. So this is the whole cycle of heart. And actually the ending symptom will be cardiogenic shock. Okay. But actually, if you understand this thing, the same is the pathophysiology of any valvular heart disease. If you understand this thing at this point of time, you can explain the same thing in any valvular heart disease, because same occurs in the gradual deterioration of a patient with valvular heart disease, with the patient with hypertension. Okay. So when you are creating problem in the heart by overburdening it, there are increased there is extra new genesis of the vessels, and heart try to compensate it. Okay. That's why, that is another reason that if heart attack, if this myocardial infarction occurs in a young patient, there are less what you say, I am missing the word, collaterals. Okay. There are less collaterals which are developed in the young age. Okay. So that's why if MI occurs in a young patient, the chances of survival are less as compared to if it occurs in a later half of the life. Okay. So that is the whole of the picture, and the same symptoms will be accordingly. Okay. Because if congestion occurs, then pulmonary edema, raised JVP, tendon pedal edema, that's what I was telling you. Okay. And when there is reduced perfusion, the urine output. Why? You see, just tell me one thing. If there is, I will ask whom, just let me ask someone of you. Okay. Okay. Who want to answer this question? Sumera, please answer this question.
Yes,
Like, for example, if there is hypertension, okay, why kidneys are shut down before actual anoxia occurs in the neurological damage does not occur, but kidneys are shut down. Why? What's the reason for it?
Sir, there is activation of the renin-angiotensin-aldosterone system.
No, this is not the
And,
answer. This is not the correct answer actually. Why
Sir, due
kidneys
to
are
hypertension,
sensitive?
there will be decreased.
Yes.
There will be decreased perfusion to the kidney.
No, but it should be in the brain as well. Perfusion should be decreased everywhere. But the answer, you are near. It have. Do you know about autoregulation? So it is related to the autoregulation. Okay. What is the limit for kidneys, and what is limit for brain?
Sir, limit for brain is 60 to 160 millimeter of the mean arterial pressure.
And kidneys?
And I don't remember exactly for
kidneys. It is 80 to 180. Okay. So that is the reason. If someone asks you why there is decreased urine output before occurrence of any anoxia or hypoxia to the central nervous system, the reason is that kidneys are shut down before, because their autoregulation level are different. Okay. So that's why if there is that same thing occur when we are dehydrated. Okay. The urine output goes down. Okay. The same thing occurs because the renin-angiotensin system activates that. Yeah, you are absolutely right. But the end result, the reason is the autoregulation. Okay. So now how to manage it? I will not go to the next slide. If someone wants to answer how to manage cardiogenic shock. Who wants to answer? I hope, Surya, your voice is better now. Try again.
Yes, sir. The cardiogenic shock can be managed by actually we have to see whether it is an acute event or a chronic sir. And if the cardiogenic shock is due to a myocardial infarction, then we have to go for the treatment of the myocardial infarction.
Very good.
And okay, and in the meantime, we have to give means to decrease the that pulmonary edema. Actually, we can support the heart with actually diuretics like furosemide.
Okay.
Then eh, we can we can actually splint the lungs with the help of CPAP. Then actually, if the contraction or the ejection fraction of the heart is less and the blood lactate level is going still high, we can start with the help of, we can use inotropic supports like
Okay.
dobutamine and all.
Okay.
And
You are missing one very important
then
thing. You have washed the water, but you have not, for example, if you have a water pipe and there is a pressure in front of it, whatever
yeah,
tape,
sir.
what would you do? Use?
Yeah,
You are forgetting that thing.
we have to decrease the pressure actually. Yeah,
What is that one?
we have to decrease. We have to decrease after load of the patient.
Very good. Okay, so
Decrease
now you
after
understand because remember
Yes.
one thing. I give you a hint. If you will try to reproduce a book, you will not be able to answer. I guarantee you.
Yeah.
Okay.
Yes, sir. Yes,
But
sir.
if
Yes.
you understand the pathology and just try, because what is the problem? Either you have to support the heart, you have to maintain the electrolytes, you have to maintain the calcium. For example, I'm just giving you. You have to strengthen tonics. You have to give the tonics, and you have to reduce the miskin heart is having pressure in front of the outlet. So you have to
Yes.
reduce the outlet pressures. Okay.
Yes, sir.
So outlet
Yes.
pressures is either in the form of afterload or
After.
in the form of treating of pulmonary hypertension. So either of them you
Yes, sir.
need to use. Okay.
Yes,
So
yes,
to
sir.
need to counteract the pulmonary hypertension, you are giving the for example, the things which are reducing or avoiding the factors which are increasing the pulmonary hypertension. Okay. So this is
Yeah.
one thing.
Yeah.
Or from the other side, what you are trying to do, you are vasodilating by AC inhibitors, vasodilating
Yes,
by
sir.
any vasodilators. You are using vasodilators for that purpose. Okay. And then you are strengthening the heart by the increasing the contractility. Okay. If you are using it
Yes.
in acute
Yes.
managed setting by IV medications, that you are either using low dose of epinephrine, either you are using dobutamine, okay, or you are using for right heart support, the drug of choice is milrinone, which is
Yeah.
phosphodiesterase inhibitor, okay.
Yes. Yes.
And there are some other medications, because I am not a physician, so there are some other medication which are supporting heart contractility, maybe some other medications which I cannot recall at the moment. But the other thing will be that you are bribing the vasculature system. Okay. So by bribing the
Yes, sir.
vasculature system, you are trying to reduce, actually, that's why not in acute heart failure, but in chronic
Yeah.
heart failure, you are giving beta blockers, and beta
Yes, sir.
blockers are reducing the heart rate. They are reducing the workload on the heart. Okay. And
Yes,
they
sir.
are,
Yes,
in
sir.
some condition, they are reducing the infundibular muscle spasm as well. So that
Spasm
will,
also. Yes.
yes. So actually that is helping you to support the heart function. Okay.
Correct, sir.
So
Correct, sir.
that is the mechanism, how you treat. And then the rest of you are cleaning the garbage by using furosemide. Furosemide is actually not the treatment of heart failure. It is just
No,
to
no, no.
clear the
That
garbage created
always
because of heart
yeah.
failure. Okay.
Yes, sir.
So in
Yes.
that
Yes.
case, if you have any, for example, like you are giving furosemide or any other thing, would you like to use, in especially in chronic heart failure, because of some other reason?
Uh,
There is another medication which is commonly used. You will find it almost every patient, spironolactone.
yes. Spironolactone, sir. Spironolactone.
Okay. because it's a potassium sparing, because whenever
Yeah.
you are using diuretics for a long time, okay,
Yeah.
then this
Potassium
patient is prone to have electrolyte imbalance, okay.
Correct.
And in some of the patients, you are also using digoxin as an inotrope, as a prevention to atrial fibrillation. This is like digoxin is actually the tonic of the heart, okay. So the word which I was using, tonic, one of them is digoxin, okay. So
Yes, sir.
digoxin is has very low therapeutic index, and it's like its toxic dose and therapeutic dose is very nearby, okay. So if you have hypokalemia, there are chances of digitalis toxicity. And by the way, this is also MCQ, that when digitalis toxicity occurs, there is hyperkalemia, okay. So that's you should be knowing the sequence for it, okay.
Yes.
So now you are supporting the heart, okay, and then you are giving some, and there are some medications, I don't remember the name, they are for generation of new vascularization in the heart, the genetic factors, they are now commercially available, and they are the patients with this ischemic heart disease, they are using it, okay. So this is the actually in this one discussion, we have discussed actually a number of aspects of cardiology, okay. And I don't think so even cardiologists are doing more than what we have discussed in this few minutes. Whatever, maybe they are discussing some more syndrome, but the business end is the same, which we have discussed. Whatever patient is medication is taking, the end result is what we have. And at the same time, you have to, because whenever there is ischemia, there are another friends which is occurring in addition to the failure, that is arrhythmias, okay. So you have to treat the arrhythmias as well. And whenever there is a stasis, this is also part of it. What is that one? Whenever there is arrhythmias, there is a stasis. What else will occur? What will be next sequelae?
Strokes means
Yes.
clotting will happen. Right?
Yes,
Clots will
clotting, the presence of clots in the chambers of the heart,
Yeah.
and that can embolize. So you need to start the anticoagulant. So you will find these patients either on warfarin or Claxane or anything. There are so many other advanced medications. I don't know much of the details, but the basic concept is that you have to make the blood thin, okay. Either by giving warfarin, when the patient is taking warfarin, then the rest of the things which you have to note that you have to continue it, you have to monitor PT, okay. And it is a teratogenic medication, but still in low doses, according to American Heart Association guidelines, it has, because this will be a surprising statement for a number of people. Even when I did not see this American Heart Association guideline, I was surprised that even if you have patient with mechanical heart valves or any compelling indication, you can continue if the dose requirement is around 5 milligram. Okay, so you have to continue even in pregnancy. Okay, so this is something surprising statement for me. Okay, and another thing is that you have to monitor INR around 2 to 2.5, like that. Okay, but the thing which you will be dealing is will be how to do the bridging. Okay, so you will be doing the bridging according to the risk versus benefit. You have to put on one side of you have to put the risks if you stop it, and the other side you have to put what are the advantages, or sorry, what are the risk for bleeding. So whenever you are stopping or continuing or decide for bleeding, you have to consideration the thrombosis risk versus bleeding risk. And if there is more risk of thrombosis, you will bridge it with something short acting. Okay, you will convert it into heparin, or there are other medications which you can use. I don't know the details, you can review them. There are some medications IV, you can use them and you can stop it, other than the traditional Claxane and heparin which we use. Okay, so this is some more details about it. So antiarrhythmics patient may be taking. One of them is digoxin, one of them is beta blocker, calcium channel blocker. Okay, so in a patient with heart failure, you will have a combo of cardiac medications which the patient will be taking. Patient may be taking aspirin. Patient may be, if the patient is recently having an ischemic event, the patient may be having dual antiplatelet therapy in the form of clopidogrel as well as aspirin. Okay. So you should be knowing the considerations in that patient. Usually on aspirin patient, you can continue. Clopidogrel, again, the same thing will be occurring, that if it is like post primary cardiac intervention, a PCI, either in the form of balloon or in the form of drug-eluting stent or bare metal stent, first generation drug-eluting stent versus second generation drug-eluting stent. Okay, you have to, there is a algorithm for it. If the people who are don't have this concept, I'm just giving you a hint, because if you don't know it, you will be stuck somewhere. So when you are preparing a topic, you have to prepare, because when that is the beauty of the exam of EDA. I will suggest you, but EDA is not a difficult exam, but EDA is such a beauty. I have appeared in a number of international exams, but EDA, I will rate that the exam was such a beautifully placed, or you can say hybrid exam between basic sciences and the clinical sciences, that they used to ask the basic sciences question and they correlate in a way that they extract all the bloody knowledge you have in your mind. If you don't have the concept, they will catch you. If you have a concept, you will never fail. Okay, but that's why I'm just correlating it. So whenever you are preparing this topic, you have to look into consideration that if it is like, I will just simply tell you that if it is only angioplasty, you have to continue it for, I think, 2 weeks. Okay. If it is simple bare metal stent, you have to continue it for 4 to 6 weeks. Okay. And if it is the first generation drug-eluting stent, which is a recent advance, you have to continue the dual antiplatelet therapy with aspirin and clopidogrel up to 6 months. And if it is the traditional first generation drug-eluting stent, you have to continue the dual antiplatelet therapy for 1 year. Okay. So this is the question which they will ask you, that they will give you a scenario and the patient will be on dual antiplatelet therapy, and they will not tell you what you to do. They will just tell you the scenario that the patient is on dual antiplatelet therapy. So at that time, you have to see what are the risks versus benefits, what are the risks of thrombosis, and what are the risks for bleeding. So you have to outweigh risk versus benefit. In emergency, if the patient is on dual antiplatelet therapy, what you can do, brother? Anyone knows what you can do in emergency?
Sir, in emergency, we can transfuse platelets.
Very good. Okay. Again, when you are giving platelets, there will be chances of thrombosis. So you have to think about it. But the way is like that. If you have a patient on warfarin coming in emergency, what you can do is either to transfuse FFPs, cryoprecipitate,
Okay.
or there is
Okay.
one new thing which they will ask you. What is that? Yes, yes. Don't be afraid. This is the answer. You are answering the correct one. Yes, prothrombotic complex concentrate. It is combination of vitamin K dependent factors. Either it is 3 factors or 4 factors. Okay. So either it is combination of 279 or I think 27910. Okay. So it's in a powder form, and again, you can use it. FFPs, if you are giving, you have to give a large volume. Okay. So you can give prothrombin complex concentrate to reverse immediately. Again, whenever you are answering this question, risk versus benefit, you have to again and again tell, because whenever you are giving such medication, there may be incidence of embolism, thrombosis, thromboembolic phenomena can occur. Okay. So FFPs, if you have a patient with heart failure, now you read somewhere, whenever you have a patient with warfarin, you have to give FFPs. The patient has ejection fraction of 30%, and you are transfusing 1 liter to correct the reverse the effect of warfarin, and now you are ending up in having patient in pulmonary edema. So you have to decide the management accordingly. But in cardiogenic shock, if you are dealing a patient with low cardiac output because of pump failure, you have to think in the consideration. You should have a clear concept of what I have told you: ischemic heart disease, heart failure, vasodilator, antiarrhythmics, anticoagulants, antiplatelets, when to reverse, when to restart, and risk versus benefit. And there is a last thing in this regards is provision of a anticoagulation team. Okay, actually these are basically cardiologists who are designated in highly highly developed hospitals. There is a coagulation team who are dealing such patients, and before surgery we just refer the patient to that coagulation team, and they outweigh the risk versus benefit. They start, restart, stop. It's their job. Okay, so this is just some additional points. So these are the things which you should be knowing when you are managing a patient with heart failure or cardiogenic shock. Okay, so now we will look at the what we have discussed and what we haven't discussed. Okay, so usually what is this PaO2? More than 70 millimeter mercury. What is PaO2? Oxygen saturation?
Partial pressure of oxygen.
Partial pressure, sorry, about
pressure.
partial pressure of oxygen in the arteries. And yesterday we discussed about mixed venous oxygen. So I was not able to look nicely. It's not looking very clear. Okay. Anyways, so restore mean arterial blood pressure more than 70. Volume correction. Okay. So that same concept of judicious fluid or restricted fluid restriction of management, resuscitation, according to the goal-directed therapy. Okay. And look for the signs of overload. That is the thing which you have. And why you want to treat the pain? Why it is important to treat the pain? What will happen if there is pain? What is the sequelae of management? Sorry?
Pain also
Sympathetic
causes
response.
sympathetic stimulation leading to
Response.
increased heart rate.
Yes, sympathetic stimulation, increase heart rate and all. And not only this thing, increase in pulmonary vascular resistance. Okay. So this is another point which should increase in pulmonary vascular resistance because of pulmonary hypertension. Stress will also mediate this thing. Okay. Arrhythmias, acid-base abnormality, you have to correct. Yes, acid-base abnormality, I forgot to tell. That if you have patient with the acidosis, even your inotrope or vasopressor will not affect. So you have to try to correct the acidosis as well. But remember one thing, you don't need to correct the ABGs. You have to look into the consideration, all the overall scenario of the patient, and then treat the patient. Okay. And remember one thing, this thing you have daily deal. Any even first year resident may be dealing with such patient. And the problem is that if you are dealing it, I guarantee you, because this topic of cardiogenic shock is not written in your holy, terrible manhus, Morgan Sharif. So nobody bothers to read it in this way, which I am telling you. But actually, if you understand this thing, whole of the cardiology will be piece of cake for you. Okay. But if you bypass and try to read separately, now today I am reading hypertension. Today I am reading valvular heart disease. No, believe me, you have to correlate all the topics and you have to read it together, step by step. You may take 1 week to understand this topic, but you have to understand in that way. What will be the symptoms? What will be the signs? What is the baseline pathology? What is the pharmacology? What is the effect of different medications? And then you will correlate that which medication is affecting at what place. Like, for example, if you are giving epinephrine, if you are giving it in high dose, it is creating more problem. Okay. If you are giving in low dose, it is very nice for the heart. It is even why I use this statement, epinephrine, if it is low, it's being used in low dose, it is good. And if it is used in high dose, it's not very good. Why? Can someone defend my statement?
It will cause arrhythmias at high dose, increase the heart rate. That will lead to more oxygen consumption.
No. There is, yes, you are right. Your point is correct. But there is another point which support my statement. That is, just try to think beta versus alpha. Just try to see at low dose which receptors are predominantly affected by adrenaline.
So at low dose beta stimulation.
Yes, Samara, please.
And then at low doses, like there will be stimulation of the beta stimulation. Then as we increase the dose, then there will be stimulation of the alpha and beta receptors.
No, but be very specific. Which beta and where? You use epinephrine in anaphylactic shock. Why?
Sir, beta receptors are
Yeah, Aditya,
Beta
just
receptor-
let her
Physiologic
finish, and if she
antidote
fails,
histamine.
just a second, please. Please, Sumera, continue.
sir, it will be stimulate the beta 2 receptors, which are
Bronchodilation. Okay, this is one thing.
yes.
And other thing is its effect on the alpha is alpha 1, alpha 2. Okay, sorry, not alpha 2, alpha 1, the peripheral vessels. Okay, so
Yes.
low dose infusion, that is anaphylactic shock, that's a little bit different explanation. But if you are using low dose epinephrine, it is predominantly acting on beta receptors. So it is helping in that way that not only it is increasing the contractility, the major vessels of the skeletal muscles, they have predominant beta 2 supply. Okay, so they are actually acting on that, and actually it is creating less stress on the heart. Okay, so if you are a problem related to contractility of heart, okay, so you don't want increase in SVR, so low dose epinephrine is a better choice. Okay, because low dose epinephrine will not cause significant vasoconstriction, and it will increase the pump function. Okay, so that is the reason. And of course, as you told Aditya, that there will be less chances of arrhythmias and there will be less chances of other side effects. Okay? So that is the concept of using epinephrine. Okay, so that's what we did: history, examination, investigation. Yes, ECG. There will maybe ECG in ischemic changes. There is one thing which is not written here in related to, in addition to ECG. What would you like to do for ischemia? It's written here. Yes, it's written here. Cardiac enzymes. Okay, cardiac enzymes. So you should be knowing when, how these enzymes are increased, what are more specific, like TROP-I and TROP-T are more sensitive and more specific than CPK or lactate dehydrogenase. Okay, so LDH and the other enzymes. So that's why, and you should be knowing when they start and when they peak and when they come down. Okay, so this is also a question which they can ask you for regarding, I cannot recall all of them, but you should be knowing it. TROP-T, TROP-I, they are more sensitive, and then CKMB, because CKMM fragment, this is for muscles, and CKMB is more specific for cardiac muscle. Okay, so cardiac filling pressures, CVP, pulmonary capillary wedge pressure, and left ventricular end diastolic pressure. 2D echo for ventricular function. Am I right? That's what we discussed before in T, in the form of transthoracic or esophageal. You are looking at the ventricular, not on the ventricular function. You are also finding the segmental wall motion abnormality, which is an early detection of ischemia. Okay, so maybe you are patient with the cardiogenic shock, going in cardiogenic shock. You can pick the patient early. Okay, and then oxygen saturation. And another important thing here, which is not written, is hemoglobin. Okay, because you have to just look out in this. This is regarding the filling pressures. This is one of them. Heart rate is one of them, important thing. And one of the important thing is hemoglobin, because hemoglobin is the car or the vehicle on which oxygen is sitting and traveling in the whole of the body. Okay, so you have to look into consideration all these things. And then your goals will be in the form of mean arterial blood pressure or cardiac index. Okay, and oxygen delivery. Okay, so for that, this one we did not discuss, but surgical intervention will be, what is the role of intra-aortic balloon pump? Does anyone know? Raise the hand and then I will ask. Who wants to answer this question? What is the working principle of intra-aortic balloon pump? Anyone knows? Mahjabeen, any guess? Intra-aortic balloon pump?
No.
Okay, Dr. Surya, yes, please.
Yeah, actually, intra aortic pump will increase the coronary perfusion actually.
Okay, very
Intraotic
good.
balloon
How?
pump. We
How?
actually we actually trying to inflate the pump at the diastole. So during the diastole, some amount of that coronary perfusion pressure will increase. So the coronary perfusion will become increase. So if some salvageable ischemic myocardium is there, so we can increase the
One thing, one aspect. The other
contractility.
thing, so when it contracts, it creates pressure towards the heart. So coronary perfusion is improved in the diastole. Okay. So this is one thing. What else? When it dilates, when it relax just before systole, what happens?
It helps in reduction of the afterload.
Very good. You are sure. Then why you are reluctant? You know, there is no mechanism of hitting through the Zoom meeting. So don't be afraid. Don't be afraid to answer
Yes.
wrong. Okay. Your answer is correct.
Yeah.
So the intra-aortic balloon pump it's a counter pulsation balloon pump which is periodically pumping. Okay. And what it does, it is placed through the radial from any arterial system, femoral artery or radial artery, it is placed. Okay. And it is placed in the aorta, and it is the function is that when it contracts, it is pushing the blood on the backward pressure, and it is supporting the coronary perfusion. And just before systole of heart, it relax. When relaxed, it is creating a negative pressure, which is reducing the afterload. Okay. So heart, it is helping the heart in two ways. It is supporting the perfusion, and it is reducing the pressure on the heart. Okay. So this is we might discuss in detail sometime, but this is the basic principle of intra-aortic balloon pump. There are so many complications related to it. A perfusion is there, it can rupture, and there are so many, but the basic concept is like that. It is supporting the coronary perfusion. What else? Angioplasty. Angioplasty is opening, seeing the angiography is seeing the vasculature and opening it either through the balloon only dilatation, or putting a bare metal stent, or putting the drug-eluting stent. Cabbage, everyone know cabbage is to have make the bypass channels. Okay. So the bypass channels just to have the perfusion. Okay. And cardiac transplant, it's available, by the way, in one of the hospital where I worked. I did not see myself because the separate team was covering it. But actually, once I saw a patient with cardiac transplant coming to me in the anesthesia clinic of the same hospital. So I was looking at it. So there, we will discuss, inshallah, one day what is the physiology of a heart transplanted patient. Okay. Another thing which is not written here, I don't know much of the details about it, but it is also in this list, is ventricular assist device. Okay. It is somewhere assisting the left ventricle. I don't know much about it, but you can count that thing in the list as well. Okay. The pharmacological support is reducing the preload and afterload. Loop diuretics is reducing the volume. Okay. And thiazide diuretics and decrease volume where excessive preload exists. Okay. And then afterload decrease by decrease SVR, decrease pulmonary vascular resistance by vasodilators. Okay. And then we discuss about dobutamine. Dobutamine actually is a beta 1 and beta 2 receptor agonist, and it is the problem with the dobutamine is severe tachycardia, which is not a nice thing. And another thing is vasodilatation. So actually, it can decrease the blood pressure. It has very very significant vasodilatation. So it can cause actually problem. So dobutamine in modern anesthesia, its use is quite decreased, and actually it is replaced somehow by milrinone. Milrinone is a better choice, as relatively less vasodilatation as compared to dobutamine. Plus, as I told you, low dose epinephrine. It's a wonderful medication. It's a wonderful medication to use. Okay. Dupixamine, somehow I have no idea about it. it has beta 2 or dopamine energetic. I don't have, I have never used it, so I don't have any experience to tell about it. Okay, this thing which is written here, the concept is finished now. Is nowhere it is written in the older books. It's still written dopamine renal dose. So it is not the concept now. It increases the contractility and increases the perfusion pressure. So that is the reason for maintenance of coronary, this one, renal supply. It is not the reason because of some special effect on the dopamine receptors in the kidneys. Okay. So I think we have covered a number of important aspects of cardiogenic shock. Anything which is not clear, you are free to answer before, free to ask if before we finish. Yes. Are you clear? Okay. So tomorrow I will tell you the time. Actually, tomorrow at night, around the same time which we usually do, there will be a little different mode which we used before. Actually, we started with the cardiac evaluation on Saturday, last Saturday, and there will be a presentation by one of the doctor probably. And the topic will be on ECG and non-invasive blood pressure monitoring. Okay. So otherwise, I will try to have the session in the morning around 3 p.m. Most probably I will, but I will confirm you the time. Okay. So any questions? Anything you want to discuss or anything ask? Everyone is clear? Okay. Thank you very much.